In our second talk on renal homeostasis, we're going to look at calcium, magnesium and phosphate homeostasis and the role of the kidney in maintaining a balance of these electrolytes. Just to remind us of the patient we spoke about earlier, this lady is going to show up in all the talks, and we'll talk about the effect of calcium, magnesium and phosphate homeostasis in this patient at the end of the talk. So again, just a reminder of what is homeostasis. And now we're going to talk about a 53-year-old diabetic with chronic renal failure who presents to the emergency department with intermittent cramps and palpitations. His ECG shows prolonged QT interval. So let's think a little bit about electrolyte abnormalities that might account for this presentation. The role of the kidney in maintaining calcium homeostasis, and the likely cause of this patient's hypocalcemia. So when we look at a prolonged QT interval in a patient like this, we need to think about hypocalcemia, but also hypomagnesemia and hypokalemia. The three of these can actually go together. After we talk about calcium and magnesium homeostasis, we'll spend a little bit of time just going through primary, secondary and tertiary parathyroidism in the patient with chronic renal disease. Okay, so calcium, magnesium and phosphate. We'll start with calcium homeostasis. And when we're thinking about calcium, we need to think about the gut, bone and kidney. These are the three organs that really regulate calcium balance in the body. Any increase in absorption of calcium from external sources must come from the intestine. The bone is the main reservoir for this cation, and the kidney controls its excretion. So if we start with the intestine, gut absorption of calcium occurs mostly in the small intestine and is regulated or is promoted by vitamin D3, which is the active form of vitamin D. There is a role for the kidney here in that vitamin D is dihydroxylated to 1,25 dihydroxycholecalciferol in the kidney, and then this active form of vitamin D then is distributed around the body to have its effect, one of which is promotion of the absorption of calcium from the gut. The bone is a large reservoir of calcium and phosphate in the body, and this is regulated by various hormones. Parathyroid hormone and vitamin D3 promote the reabsorption of bone through osteoclastic activity and therefore increase the concentration of calcium in the blood through this mechanism. Conversely, calcitonin promotes the laying down of calcium and phosphate in the bone, and acidosis actually promotes reabsorption of bone as well. What about the kidney? Well, the kidney is involved in the filtration and reabsorption of calcium and the regulation of calcium excretion. Again, this is controlled by various hormones. Parathyroid hormone increasing the reabsorption of calcium in the distal tubules. whereas calcitonin increases the loss of calcium through inhibiting its reabsorption from the tubules. There are other factors which promote an increase in calcium reabsorption, calcium loss in the kidney. These would include acidosis, so aciduria in the distal tubule promotes calcium loss. Hypercalcemia, a large load of calcium within the tubules, increases the amount of calcium lost in the urine, and an increase in extracellular fluid volume. So somebody who is hypervolemic or well hydrated tends to lose calcium, and that's one of the reasons why simply rehydrating a patient with hypercalcemia can increase the loss of calcium through the kidneys. What about magnesium and phosphate? Again, there is a relationship between the activity in the gut, kidney and bone for these electrolytes. Magnesium is the most abundant divalent cation in the body, particularly in the intracellular fluid. Its absorption is highly dependent on dietary load. So if you're taking a high calcium diet, a much lower percentage of that calcium will be absorbed. Whereas if you have a low calcium diet, the gut is able to absorb a higher percentage of the magnesium. Importantly, proton pump inhibitors, particularly with chronic usage, can inhibit the absorption of magnesium from the gut and can ultimately lead to hypomagnesemia in these patients. Renal reabsorption occurs mainly in the thick ascending limb of the loop of Henle, with some absorption in the proximal and distal tubules. Absorption is increased with PTH, parathyroid hormone, glucagon and insulin. So absorption of magnesium is increased with these hormones and decreased in the setting of metabolic acidosis, hypokalemia, and diuretic use. That's why patients with chronic diuretic use may be hypomagnesemic. Anybody with hypokalemia could also be hypomagnesemic. And in situations of low insulin, so for example diabetic ketoacidosis, hypomagnesemia can also be a problem. Finally, we'll look at phosphate. Dietary phosphate and phosphate absorption from the intestine is influenced by vitamin D3. Vitamin D3 increases the absorption of phosphate. The biggest store of phosphate is in the bone, and vitamin D3 and parathyroid hormone can cause mobilization of both calcium and phosphate from bone in situations in which this is required. Most phosphate is reabsorbed by the proximal tubules, and this reabsorption is enhanced by low phosphate diets and vitamin D3, whereas reabsorption is decreased, so phosphate loss is promoted by parathyroid hormone, high phosphate diets, metabolic acidosis, and glucocorticoids. Again, when there is an imbalance between the counter-regulatory hormones and insulin, for example in diabetic ketoacidosis, hypophosphatemia can therefore become a problem. So if we look at our diabetic patient who looks like she has DKA, from what we've been saying, this patient may well have hypophosphatemia and hypomagnesemia due to loss of these electrolytes through the kidney because of the metabolic acidosis, low levels of insulin, and relatively high levels of counter-regulatory hormones. If you have any questions about this short talk, you can bring them up in class. So we've covered quite a few electrolytes and fluid in the last two talks. In the next talk, we will look at acid-base balance. Thank you.